So, Crohn's disease is an inflammatory bowel disease, and the inflammation can occur anywhere in the alimentary canal from the mouth to the anus. So we've studied about Crohn's disease in the first lecture. It includes the etiological factors of Crohn's disease and the indices. And we have also studied about the clinical features of Crohn's disease. So in this lecture, we'll be studying about the latter half of the Crohn's disease, in which it'll include the differential diagnosis and the way how to investigate a Crohn's disease and the further management plans that we can offer to our patients. So, if we talk about the differential diagnosis in the Crohn's disease, usually the diagnosis of Crohn's disease is very straightforward. So what happens is that a patient comes and we can suspect Crohn's disease, but there's also a possibility of alternative diagnosis. So we're going to be discussing about the differential diagnosis of Crohn's disease. So the first being celiac disease. As you know that Crohn's disease, a patient presents with diarrhea. The main clinical feature is diarrhea. So we can also suspect it as celiac disease because patients of celiac disease, they also present with diarrhea. Secondly, we can suspect a patient with chronic pancreatitis, and colorectal cancer can also be one of the differential diagnoses, but this would be probably present in more aged patients. Other than that, we've got diverticulitis, which also presents with diarrhea, and different types of infections such as Campylobacter, such as Entamoeba hemolytica. There are different types of infections that can also be suspected. And then we have irritable bowel syndrome, which has a set of very vague symptoms such as constipation alternating with diarrhea. So this is also one of the differential diagnoses that we should be taking care of. And then we have ischemic colitis, we have lymphoma of the small bowel, all involving the small intestine, sarcoidosis, and lastly ulcerative colitis. As you all know that ulcerative colitis is the other part of inflammatory bowel disease. So inflammatory bowel disease consists of Crohn's disease and ulcerative colitis. So it is very necessary to differentiate between these two. So I'll be discussing how to differentiate ulcerative colitis with Crohn's disease. So the initial evaluation of Crohn's disease consists of a thorough history taking, and with that a thorough examination, and then a few lab tests that can take us to the diagnosis of Crohn's disease. So history taking usually has some key points that we should be taking care of. And these points, their severity and their duration. So these are the things that are most important in the history taking of Crohn's disease. So we can start questioning the patients with any recent travel if they've been to a country where there's an endemic of any infections. We can ask about different types of medications they're taking. For example, patients who have started an antibiotic course, they're more prone to getting infections which can cause diarrhea. Other than that, we've got different diets that can also cause diarrhea and can be differentiated with Crohn's disease, such as having food from outside, uncooked meat, etc. Other than that, we can also ask about the sexual preferences and different types of sexual activity. And family history of inflammatory bowel disease is very, very necessary. It's very crucial to ask about the family history, but it does not really guarantee having an inflammatory bowel disease, but it can raise the level of suspicion. Other than that, reviewing the symptoms of Crohn's disease, such as any extra intestinal manifestations and any weight loss that the patient might be presenting with, is very necessary to be asked during history taking. So, examination is very necessary for Crohn's disease. The most importantly, the abdominal examination. In that, we can start off with the perineal and the rectal examination to see if there is presence of any gross or occult blood. And other than that, as we all know, that abdominal examination is very necessary to see any tenderness, any mass, or any physical signs on the skin of the abdomen. So there are different types of lab tests that we can we can take the patient to. For example, there are a lot of lab tests that might present as normal, but we have to rule out a lot of different diseases such as IBD, such as inflammatory bowel syndrome, and different types of diseases. So anemic patients are foremostly, it's very important that we take the lab test of iron, folate, and vitamin B12 deficiency to rule out any kind of anemia. Other than that, WBC count may be normal or may be elevated. There are some band forms that suggest any complications such as the pyogenic complications. Elevated C-reactive protein and elevated ESR is very necessary because some patients may present with vague symptoms, and like I've told you, they might present with inflammatory bowel syndrome. So it's very necessary to rule out inflammatory bowel syndrome foremost. And then different stool samples must include with stool culture, examination for ova and parasites, and testing for Clostridium difficile infection is very necessary before starting any invasive procedures such as barium studies or endoscopy. So these are the sets of tests that should be done before any of the invasive procedures. Lastly, serology for entamoeba histolytica is very necessary. So these are the lab tests that can be done in the lab, can be done in the OPD before starting off with the more invasive investigations such as endoscopy, CT, and MRI. So ultimately, the diagnosis of Crohn's disease is done by findings in the CT enterography, imaging studies, and histopathological slides. So what really happens is that barium studies is usually have been the mainstay treatment investigation for Crohn's disease, and it was done for the following reasons, such as one, that it accurately localizes the location of the Crohn's disease within the small intestine, and secondly, it provides the evidence of very active inflammation within the small intestine. But now barium swallow has been replaced with CT, and CT has replaced barium swallow, and the standard CT has not been very useful. It does not really show the findings that are necessary to be found within the small intestine, but it also usually shows us a normal small intestine. But other than that, the CT enterography has been very useful, as we can see in this picture. We can see that there is a stricture with pre-stenotic dilatation. So we can see the mural thickening within the small intestine, and we can see mural enhancements within the small intestine with the help of this CT enterography. Secondly, MRI enterography has also been very helpful. It has worked with the CT enterography, such as in this picture, we can see that there is mural thickening, and there is also the presence of mural hyper enhancements, and there's a very specific sign that we can see, which is a very prominent sign of Crohn's disease and is solely present only in patients with Crohn's disease. That is the calm sign. As you can see in this picture, this is the calm sign. It resembles the teeth of a comb. So MRI enterography has also been very useful. We give a patient a drink which consists of a contrast, and we ask the patient to swallow the drink, and with that we get our MRI done, and we can see these signs. MRI has a lot of advantage as compared to CT enterography. Advantages such as there is very less soft tissue contrast, and there is also very less ionizing radiations that affects the body. So lastly, endoscopy has been one of the main prime ways how we can suspect, how can we investigate a patient with Crohn's disease. So, endoscopy has also helped us in taking biopsies, and these biopsies are then sent into the histopathological labs, and they are seen under the microscope, and we can see different types of changes within the epithelium of the small intestine. As you can see in this picture, we're seeing through the endoscope, we can see through the camera, and we can see that there are these aphthous ulcers. So what exactly is aphthous ulcer? So aphthous ulcers are usually characterized with the depression, which is white in color, and it is surrounded by an erythematous rim. So as you can see in this picture, there is a white depression, and around it there is a redness. There's an erythematous ring around this ulcer. So these are specifically called as the aphthous ulcers. So in this second picture, we can see a massive presentation of the Crohn's disease. As you can see that we are able to differentiate edema, erythema within the walls of the small intestine. As you can see that there is this all wall of the small intestine is edematous. It has different types of inflammation. And secondly, we can see that there's redness within the wall, so it's very erythematous, and this gives a very specific type of appearance, which is very relative to Crohn's disease, and it's called as the cobblestone appearance. As you can see, this endoscopic picture represents a cobblestone, so there is the name cobblestone derived from the cobblestone. So this is one of the very different picture of an Crohn's disease. Thirdly, we can see that there is a different type of ulcer, which is called as the stellate ulcer. So this usually just consists of a ring which is just erythematous, and we can see this is a part of the terminal ileum. And lastly, in this picture, we can see that there are discrete ulcers within the small intestine, and we can see that there is a slight erythema with these discrete ulcers, and there's patchy inflammation, which is typical for this Crohn's disease. So these are the different types of ulcers that we can only differentiate with the help of an endoscope. There's also a thing called as VCE, which is a video called endoscopy, which is very useful to differentiate different types of small lesions, such as these ulcers, in a patient with Crohn's disease. So now if we talk about the differences between Crohn's and ulcerative colitis, like we've mentioned before, that Crohn's and ulcerative colitis, they're both the diseases that is present within inflammatory bowel disease. So like inflammatory bowel disease is either Crohn's disease or ulcerative colitis. So that is the reason why that it's very necessary to differentiate between both of these diseases, as they're very similar to each other. So we'll be seeing how to differentiate between Crohn's and ulcerative colitis based on micro presentations within the intestine and some macro presentations. So first, coming up to the aphthous ulcers, like I've shown you the picture of aphthous ulcers in the previous slide. Aphthous ulcers are very typical to Crohn's disease. So aphthous ulcers aren't present in ulcerative colitis. But instead of aphthous ulcers, there are a lot of micro ulcers, very typical micro ulcers that can be present within the small intestine of a patient with ulcerative colitis. Secondly, a very distinguishing feature which literally differentiates between both of these is that Crohn's disease, like I've mentioned before, can be present throughout the alimentary canal. It can be present from the mouth until the anus, any part of the digestive tract. But other than that, ulcerative colitis is very much limited to the proximal part of the colon. So Crohn's disease is discontinuous and it is very asymptomatic. And such as ulcerative colitis, it has more of a continuous type of appearance and it is very symmetric. Other than that, if we talk about the involvement of ileum, so as it can be, Crohn's disease can be present anywhere in the alimentary canal. So 75% of the involvement is within ileum. So ileum is the part that is most affected. But in ulcerative colitis, ileum is usually spared, and like I mentioned before, that is it has more of a distal part of involvement. So the colon is mostly, the large intestine is mostly involved in ulcerative colitis. So if we talk about the perianal complications, Crohn's disease is very much popular among the perianal complications, such as skin tags around the perianal area, or anal tags, we could call it, or the presence of perianal fistulas or perianal fissures. These are the complications that can occur with Crohn's disease. But with ulcerative colitis, you wouldn't be able to see any perianal, any complications such as anal tags or any fistula or any fissures. So if we talk about the serosal findings, we can see the serosal findings in Crohn's disease, which can be presented such as erythema and creeping fat, but serosal findings are completely not present with ulcerative colitis. So, like I mentioned before, a perianal complication, fistulas are present within Crohn's disease. A patient who have had long-lasting Crohn's disease are very prone to this type of a complication, which the patient might present with pain and discharge within the perianal region, which is typical of fistulas, and fistulas are absent in ulcerative colitis. If we talk about another complication, strictures are usually present in Crohn's disease, whereas in ulcerative colitis, strictures are very rarely present. There are probably a very few patients who have come up with strictures if in regard to ulcerative colitis. If we talk about the granulomas, granulomas are a feature of Crohn's disease as compared to ulcerative colitis. Among 15 to 60% of patients might present with granulomas within the small intestine if we look through the microscope, but granulomas are not present in ulcerative colitis. So this is a very distinguishing feature among both of these diseases. If we talk about the depth of involvement of this disease, so Crohn's disease, it involves the mucosal, the submucosal, and the transmural involvement. So it involves almost all the layers of the intestine. But if we talk about ulcerative colitis, it is only very limited to the mucosal and the transmural layer of the epithelium. And if we talk about rectal sparing, so like I've mentioned before, Crohn's disease is usually present throughout the alimentary canal, but it kind of spares the rectum part of the digestive tract. So it's either complete or relative rectal sparing, but ulcerative colitis, like I've told you, it's more of a distal part of a disease. So it does involve the rectum or a part of the large intestine. So, if we talk about the measuring disease activity, so what really happens is that in daily practice, it's usually very sufficient to grade a patient with the help of sign and symptoms, to measure the activity of the disease with the help of sign and symptoms. And it's very rarely advised to get a patient uh, go through such radiological investigations all over again to see the extent of the disease, to see if it's expanding or not. So it's very rare. But to help this part, to help the measuring disease activity, there are a lot of different indices that has helped us in measuring the disease activity. I'll be mentioning a few, such as the composite scoring systems includes Crohn's disease activity index. This is the main index that we can measure the disease activity. Secondly, the Van Hees index has also been very popular among measuring the disease activity. The Cape Town index and the Harvey Bradshaw index has also helped in certain the sign and symptoms based disease activity. And that there's an international organization of the inflammatory bowel disease, which is also one of the indices that can help us measure the disease activity. Other than that, there is the St. Mark's Crohn's index, which is also popular but rarely used. Then there's the D. Domble's index, and lastly, there's the Talstad index. These are the indices that have very rarely been used, but the foremost popular indices is the Crohn's disease activity index. So if we specifically talk about the Crohn's disease activity index, so what really happens is that we're going to be seeing the different sign and symptoms, okay? And then we're going to be scaling these sign and symptoms. How does the patient present? Do they present with a very mild type of a symptom, or they are presenting with a very severe type of a symptom? And then what we're going to do is that we are going to multiply it with the weight, and then the sum of all these variables are able to help us to differentiate with remission or more severe illness. So first being the liquid or a very soft stool. So we're going to be asking the patient that is his loose stool very is his loose stool very common throughout the day. We're going to be asking about the number of times that he goes to the washroom for this type of a stool, the loose stools. So it's going to be counted on a daily basis, and then we're going to be counting it for a consecutive 7 days. And then this scale will be multiplied with the number 2. Secondly, we'll be seeing if the patient presents with abdominal pain. So if a patient, this is going to be scaled on an everyday basis. So if a patient does not present with abdominal pain at all, so it'll be 0 multiplied by 5. And then if a patient has mild type of abdominal pain, then it'll be 1 multiplied by 5, and consecutively, if moderate, then it's going to be 2, and severely in abdominal pain, the 3 will be multiplied by 5. But this would be a sum of a consecutive 7 days rating. So if we talk to the patient about if he's generally feeling well or not. So this will also be a sum of all the consecutive 7 days. So if he's completely well and he doesn't have any type of a symptom, so it'll be 0 multiplied by 7. And if he thinks that he is slightly sluggish or slightly lazy and he doesn't really feel well, it'll be slightly below the par, and it'll be 1 multiplied by 7. And then if he feels poor, it'll be 2 multiplied by 7. If he feels very poor, it's going to be 3. And if he feels completely terrible, it'll be 4 multiplied by 7. So this scale is going to be measured on a daily basis for 7 days. So the next feature that we'll be seeing is of the extraintestinal disease. We're going to be focusing on the features that is other than related to the digestive tracts. So we could also call it as the extra intestinal manifestations. So we would be seeing that during the 7 days course, is he or she presenting with any of these extra intestinal manifestations, such as if he is presenting with arthritis or arthralgia, any type of bone pain, any type of muscle pain, so we will be multiplying it with 20. And then secondly, if we ask him during the 7 days course, has he presented with any skin or any mouth lesions, we'll be multiplying it with 20. Similarly, any changes in the eyes, any inflammation of the iris or inflammation of the uveal tract, so it'll be also multiplied with 20. And fourthly, like I've told you, that there are a lot of perianal complications that can erupt with Crohn's disease. So that could be any anal fissure, any anal fistula, any perirectal abscesses. If the patient presents with, multiply it with 20. And then lastly, any other external fistulas other than being specific to the perianal region. And lastly, if he does present with fever more than 100 Fahrenheit, we are going to be multiplying it with 20. So we're going to be asking him if he's taking any medication for his diarrhea, if he's taking opiate for his diarrhea, which is one of the main clinical feature of Crohn's disease. If he isn't taking any medicine, we'll be multiplying it with we'll be multiplying 0 with 30. And if he is taking any medicine, then we'll be multiplying it with 30. After the physical examination, after the abdominal examination a doctor does, he would be seeing if he notices any abdominal mass within the abdomen. So it'll be 5 multiplied by 10. And if he is not really sure, he has some doubts with the mass, then it's going to be questionable and 2 multiplied by 10. And if he doesn't feel a mass at all, so it'll be a complete 0. And then we'll be seeing at the hematocrit level. We're going to be seeing at the lab values too. As you know, hematocrit value for males is around 45 to 52, so around 47 percentage. If it goes low or high, then we'll be multiplying it with 6. And similarly for the females, if the hematocrit level is around 37 to 45, that's the normal range. But if it's more than that or if it's less than that, then we will be multiplying it with 6. And then lastly, we'll be seeing the percentage of the body weight if it's below the standard. So below the standard means that the normal weight of a normal person as compared to his weight and his height. So 100 is going to be multiplied with 1 minus the division of body weight and divided with the standard weight of the patient at that age and that height. So if there is a decrease in his body weight, we'll be multiplying it with 1. So ultimately, what really happens is all these variables that we've come up with the sum, we're going to be adding all of these weightages, and the complete sum of this index then helps us in measuring the disease activity. So if the patient comes up with 150, which mostly is less than 150, so the patient, we can say that the patient is in remission. And if the patient comes up with a number that is more than 450, we are going to be labeling him as the patient has a severe illness of Crohn's disease. So, if we come to the management plan of treating patients with Crohn's disease, so we will be starting with Crohn's disease medical therapy first. So, in the medical therapy, as you know, we'd be introducing medicines to the patients with Crohn's disease. We will be starting with aminocyclates. So, aminosalicylates have been used in the treatment of Crohn's disease for a very long time. And if we specifically talk about sulfasalazine is the parent compound which was developed by a Swedish researcher, and his name was Nana Schwartz in 1938. So he was the one who discovered sulfasalazine, and sulfasalazine has a very drastic effect on treating the patients with Crohn's disease. If we talk about some of the side effects of sulfasalazine, it includes anorexia, dyspepsia, and the usual nausea, vomiting. If we talk about another category regarding 5-aminosalicylates, it is the sulfur-free aminosalicylates. So these are the drugs that does not contain sulfasalazine. So these include the mesalamine and the ulcerative, and lastly the balsasalazide. So this category, usually the side effects includes such as headache and fever. If we talk about the other kind of medicine that can be introduced to patients with Crohn's disease are the antibiotics. So usually antibiotics can control the more of a pyogenic complications that occur in Crohn's disease. Antibiotics such as metronidazole and ciprofloxacin. The side effects for metronidazole as very common side effect is the very sour sort of a taste, and other than that there is anorexia, nausea, vomiting, and headache with antibiotics. So if we talk about glucocorticoids, these steroids have also had an effect on treating patients with Crohn's disease. So it usually is applicable to give steroids to those patients who are mild to moderate in the illness, and who have not been treated with primary therapy, so they haven't had any effects with primary therapy. So we can give them steroids to the patients with moderate to severe illness. So glucocorticoids, such as the classic ones and the novel ones, and some of the side effects of glucocorticoids are such as sleep disturbance and mood disturbance and cataract and glaucoma. So there are a lot of side effects regarding glucocorticoids. So other than that, a good sort of a medicine that are given to Crohn's disease patients are the immune modulators. So these thiopurines are very effective, such as 6-mercaptopurine, the azathioprine, methotrexate, and cyclosporine. They have a very drastic effect on patients with Crohn's disease. Some of the side effects of immune modulators are such as drug and fever and arthralgia. So if we talk about the biological response modifiers, so we are specifically talking about the antibiotics. Which antibiotics? These are the anti TNF factor antibodies. So these include the infliximab, which is one of the prime medicine of anti-TNF factors, and other than that we have adalimumab and we have certolizumab payroll. So some of the side effects of these are anorexia and nausea, vomiting. Other than that, within the biological response modifiers, we have another group which is very specific to. There's only one medicine in this group. It is the natalizumab. So it is slightly different than the group that we have mentioned before. And for these, the side effects are a little rare. They include the upper respiratory tract infections, and TB is also seen in patients using these type of medicines. So, other than the medical therapies, there are a lot of adjunctive therapies that also help in suppressing the different types of symptoms in patients with Crohn disease. There are these type of therapies are helpful in treating different types of complications and different types of symptoms of Crohn's disease. Firstly, the antidiarrheal and the anticholinergic agents, they help in suppressing the symptoms such as the diarrhea and cramping, which is very common in patients with Crohn's disease. Thirdly, usually patients are very anemic, and anemia could be because of ileal resection, or they could be having a vitamin B12 deficiency anemia. So, ileal resection or any operation surgery done on the ileum, these patients they are very helpful with the parental vitamin B12. Other than that, cholestyramine and colsevilam have been helpful in bile salts diarrhea, which is a very specific type of a diarrhea which only includes bile salts. Other than that, bone loss management is very important in Crohn's disease because of the reason that there is a low in the bone density. When there was a research done in some of the patients of Crohn's disease, they went through the investigation regarding to the bone. So they've seen that there is a decrease in the bone density. So we have to manage it medically. And other than that, smoking cessation can be helpful in decreasing this bone density decrease. Other than that, calcium, vitamin D supplements are also helpful in increasing the bone density, and bisphosphonates are lastly the medicines that can also help in preventing the decrease in bone density. So, if we talk about a specific nutritional therapy, so what really happens if we see in this graph is that there is an active Crohn's disease, and then there's a Crohn's disease in remission. So, remission, if we talk about the definition of remission, it is the evolving. So the evolving of the Crohn's disease. A patient in remission is good because it helps the patient to heal more quickly, and it's relatively less as compared to a patient in active Crohn's disease. So there's a lot of chances that patients who are healing, who are in remission, they have a relapse and they go back into having active Crohn's disease. So in active Crohn's disease, we usually treat the patient with the induction therapy and microbiota modification and give them different types of medicines. And they're very exclusive to enteral nutrition. So what exactly is enteral nutrition? What really happens is the patient with Crohn's disease, we don't give them anything through mouth. So they aren't eating anything. What really happens is that we pass a tube through their mouth into the esophagus, into the digestive tract, and they are given calorie, and they're given 100% calorie and nutrition through this tube. So this is the enteral nutrition which is seen in patients with Crohn's disease. It's an active treatment option. And other than that, in the patient with who are in the remission, what really happens is that we have to maintain the healing process. So they're very considerable about what kind of diets that can be presented to the patient. So there's a defined whole food diet and then defined formula diet, different types of diets that can be available for these patients. Other than that, there's empirically determined proportions. So we're supposed to give a very balanced diet to these patients. So this is the nutritional therapy. So lastly, if we talk about the surgical therapy, as we've talked about the medical therapy, what are the surgical options that we can offer to the patient? So if there's a patient who have had Crohn's disease, there's a very integral role of surgery in patients who are not responsive to any type of medication that we provide. Either it's sulfasalazine, either it's methotrexate, either it's any of the TNF factors. So those patients, they're usually more responsive to surgical therapies. So, what are the specific indications that require surgeries? First, being intra-abdominal abscess. If there's an abscess within the intestine wall, so the patient requires surgery as soon as possible. Other than that, if there is a medically intractable fistula, so like we've mentioned that fistulas and fissures are one of the complications of Crohn's disease. So if we cannot find out the fistula, where is it coming from, where is it going, so a surgery is needed. If we see a fibrotic stricture with obstructive symptoms, as we've mentioned before, that Crohn's disease is very prone to having fissures and strictures. So if there's a stricture that is completely obstructing the intestine, we need to do surgery as soon as possible. If there is a complication such as toxic megacolon, which is very common in Crohn's disease, as it can completely obstruct the digestive tract, so surgery is required. If there's any hemorrhage, if the patient presents with bleeding in their stool, whether it's dark or occult or red blood, so we need to figure out where is the bleeding from, and we need to treat it right then and there. And lastly, if the patient has cancer, so we have to go through surgical therapies. So surgical therapy usually, there are different types of surgical therapies that we'll be discussing right now, but surgical therapies are not usually used. I mean, patients usually respond to medical therapies, and surgical therapy is very rarely used. So one being the limited small bowel resection. In this, only the part where the Crohn's disease has been affected in the small intestine. So only that part of the bowel, that part of the digestive tract is resected. Resected means that the part of the intestine is completely removed. Other than that, there is a complete bowel resection if the whole ileum is involved or the whole colon is involved. Then we're going to resect the whole part as a whole. This usually occurs in patients who are children. And lastly, there's the ileal pouch anal anastomosis. If a patient is not complying to any of these other small bowel resections, then we can offer IPA, which is ileal pouch anal anastomosis. So there are a lot of drawbacks to this surgery. What really happens is that there is a relapse of this pouch, so this is not usually recommended, but it's one of the types of surgeries that are available. So that's all from this lecture, the part 2 of Crohn's disease. So what have we studied throughout this lecture, the second part of Crohn's disease? We've studied about the differential diagnosis of Crohn's disease. There are a lot of diseases out there that are very similar to Crohn's disease, one being ulcerative colitis itself, and other being the celiac disease, any sort of lymphoma, sarcoidosis. There are a lot of differential diagnoses that we need to rule out. And then we've studied about the different ways to detect Crohn's disease. First of all, the regular history taking examination and different lab tests, but ultimately endoscopy is the only way that gives a clear view of what exactly is going on in the small intestine, and how what are the different types of ulcers, and what are the what are the lesions within the small intestine. So endoscopy is the prime way to investigate a patient. Other than that, we've studied about the different management ways that we can offer. For example, the medical therapy. There are a lot of different types, varieties of medications that are all equally effective. And other than that, we've studied about the different medicines that can be used symptomatically to treat a patient symptomatically. And then we have studied about nutritional therapy. What is nutritional therapy? What is a patient who's in active Crohn's disease and in a remission Crohn's disease? And lastly, different types of surgical therapies that we can offer to a patient with Crohn's disease. So I hope you've liked our lecture today. So keep watching sqadia.com, and thank you very much for watching.